Hello, I am Dr. Chandrashekara S, Director and Rheumatologist at General Rheumatology and Immunology Center, Bangalore. I have no conflict of interest to disclose. I will be discussing about how one should interpret the tests that we suggest while evaluating a rheumatology patients. Rheumatology is one of the specialty which depends heavily on clinical history examination of the patients. Though investigations are required, they are not very specific and they are also not very sensitive to pick the diagnosis. Hence, interpreting the test results with reference to clinical features to make diagnosis and also to understand about the patient becomes essential. Normally, in a patient suffering from either arthritis or any of the musculoskeletal diseases, we do test to fulfill 5 of the primary objectives. The first objective is to establish whether the given disease is inflammatory or non-inflammatory in nature, and subsequent is to confirm the diagnosis. If it is inflammatory, the type of inflammatory disease, or if it is non-inflammatory, the type of non-inflammatory causes of the musculoskeletal disease. Once we confirm the diagnosis, we try to evaluate the condition to understand the extent of the disease, or also to understand the amount of the damage that has been caused by the disease, and also to understand the probable organs the disease may affect during the course of time. The fourth objective is to figure out, is there any other associated condition like liver disease, diabetes, hypertension, kidney disease, presence of infection or lung conditions, and also to do certain other tests which could help us to monitor the response to therapy as well as about the progress of the disease. So the first initial requirement is to establish the inflammatory nature of the disease. To establish the inflammatory nature of the disease, we depend on 3 of the key factors. The first key factor is the clinical features, which serves as one of the important parameters to differentiate whether the given condition is inflammatory or non-inflammatory. The symptoms like early morning stiffness and the difficulty to move the joints, especially after a prolonged rest, is one of the clear indication of the presence of inflammation in the joint where the patient is complaining of the pain. So in addition to that, when we evaluate or examine the respective part, the signs like the swelling, the tenderness, presence or absence of the discoloration of the joint will also help us in differentiating whether the given condition is inflammatory or non-inflammatory. The clinical information is essential, especially when you are trying to interpret the inflammatory parameter, raised inflammatory parameters. Basic reason is the inflammatory parameters are non-specific. Both ESR and CRP can rise in any condition which leads to inflammation, which include infections too. So as a result of which, the history plays a crucial role. For example, if the patient has elevated ESR or CRP, simultaneously he has symptoms suggestive of possible infection in the throat, possible presence of an abscess, one has to attribute the possible elevation of ESR CRP to the existing conditions also. So interpreting these parameters becomes very crucial. For that, the clinical history and examination plays a lot of supportive role. So how one can use these 2 parameters, ESR and C-reactive protein. C-reactive protein is measured from the serum of the patient, and one of the biggest advantage we have is we can store the serum, and it is not necessary it should be assessed immediately or within few hours, and the CRP happens to be one of the direct measure of the inflammatory process, because CRP is secreted in response to the inflammatory cytokine, whereas erythrocyte sedimentation rate ESR is more of an indirect measure because increase in ESR reflects increase in fibrinogen. The increase in fibrinogen is a direct effect of the inflammatory cytokine. So hence ESR is considered as an indirect measure, and it also influenced by several other factors like gender, the age of the patient, presence of pregnancy, and the temperature in which the test was set up, and some of the drugs like salicylates, etc., which alters the surface resilience of the RBCs, shape of the RBCs, and to some extent even presence of anemia or increases the ESR, whereas polycythemia decreases the ESR. So several factors do influence ESR. In contrast, CRP is not influenced by majority of these factors except smoking, because smoking per se produces inflammation, and as a result of which the CRP could be raised. So even the temporal profile of both ESR and CRP do vary. CRP is secreted or increased almost 3 to 4 times or sometimes even 100 times depending on the stimuli which incites the inflammation. Within 2 to 5 hours, sometimes as late as 7 hours, but usually within 2 to 7 hours, the CRP starts rising up. It may continue to rise till the inflammation continues, and once the inflammation recedes, normally in 2 to 3 days, it starts dropping down, and by the end of 7th day, normally it goes for a complete resolution or complete reduction. In contrast, ESR is a slower response. It takes up to a weeks to peak and also takes several weeks to recede. And we also have to alter or modify the ESR, or we call it as correction of ESR. So simplest way of looking at the normal range of ESR is age divided by 2 in case of men, and it is age plus 10 divided by 2 in case of female. So that's how you can look into calculate an approximate normal value based on the age range. So having established whether it is inflammatory in nature, then we need to proceed to confirm the diagnosis. To confirm the diagnosis, the tests like CBC, liver functions, urine routine, and few other regular tests which we do also helps us in consolidating the diagnosis. Specific tests like rheumatoid factor, ASLO, ANA, ANCA, and some of these tests also helps in confirming the diagnosis. Radiological and other imaging studies, and if required a synovial fluid and biopsy do help in confirming the diagnosis. How we should interpret complete blood count? For instance, if there is a drop in hemoglobin, the drop in hemoglobin could be because of a persisting chronic inflammation, which we call as anemia of chronic disease, or it could be because of hemolysis, which suggests a possible lupus, and alternatively there could be a blood loss, which also gives you some clue about inflammatory bowel disease. Similarly, WBC count, when it is increased, suggests there is a severe inflammatory condition, especially like systemic onset JIA, vasculitis, Kawasaki disease, where you see the WBC counts being higher. It could be reduced in the infiltrative disorders like leukemias, and in systemic lupus erythematosus, and also it could be sometime because of the drugs that the patient is taking like methotrexate or azathioprine. Similarly, increase in platelet can be seen as a component of acute inflammation, which especially we see in pediatric population in juvenile chronic arthritis. Reduction in platelets are seen in systemic lupus erythematosus and sometimes as a part and parcel of the side effects of drugs like methotrexate or azathioprine. So then one has to perform urine routine examination, especially when you are considering a possible differential diagnosis of connective tissue disease or vasculitis, urine routine is a must. We need to look for active sediments in the urine, especially in the lupus, vasculitis, and several other connective tissue disease which can affect kidneys may have positive finding in urine routine. Similarly, presence of proteinuria suggests involvement of the renal system by systemic lupus erythematosus. We do see in connective tissue disease and vasculitis. Sometimes the signs of urethritis may also be there. It is reflected in the urine examination by increased pus cells and presence of the active nitrate reductions. And sometimes even if you examine with gram stain, you may see bacteria, especially one can identify gonococcal infections. These all can present like a reactive arthritis. Discolored urine can reflect several metabolic disease. The best one of them is alkaptonuria, where you can have a black colored urine after after the urine stands in the one can see the discolored urine. The other biochemistry profile, like liver function test. When you do liver function test, if there is a complete abnormality in the liver functions, the possibility of autoimmune hepatitis or possible association of autoimmune hepatitis with a connective tissue disease should be considered. In a scenario where there is isolated elevation of SGOT, SGPT, which we sometimes call as transaminitis, if it is present, one need to consider a possibility of these two enzymes, because both SGOT and SGPT also are sourced in muscles. So as a result of which, if you have an isolated SGOT, SGPT elevation with minimal or normal GGT, one have to consider a possible muscular disease. At that time, one can ask for creatinine phosphokinase, CPK, NAC, which if it is elevated, clearly suggests a possible muscle disease. The entire clinical symptoms and signs could be part and parcel of muscle disease, or the disease in question may also be involving muscles. Elevated alkaline phosphatase, especially isolated elevated alkaline phosphatase in the presence of musculoskeletal symptom, should suggest a possible metabolic bone disease related to either vitamin D deficiency, parathyroid hormone disease, and sometimes even the renal disease can present with elevated alkaline phosphatase, or varieties of other bone diseases can also manifest with increased alkaline phosphatase. The other tests like elevated creatinine suggest renal disease, altered electrolytes suggest the associated metabolic disease, sometimes renal tubular acidosis, especially when the patient has hypokalemia. Elevated sugar suggests uncontrolled diabetes, and diabetes can, especially prolonged uncontrolled diabetes, can present with several musculoskeletal manifestations like frozen shoulder, the small joints of the hands pains, but several other musculoskeletal symptoms may be present in uncontrolled diabetes. Elevated serum uric acid suggests gout, but one need to remember all elevated uric acid is not equal to gout, and one should establish the relationship of elevated uric acid to the joint pain or acute attack, because sometimes the conditions like psoriasis, where there is a high cell turnover, the uric acid may be elevated. Presence of renal involvement, especially with a mild to moderate renal failure, can also have elevated uric acid. So presence of uric acid suggests gout, but we need to exclude the other possibilities, especially when the clinical presentation is not like gout. Usually gout presents with episodic, acute, severe or excruciating pain, especially in the joints of the foot, but sometimes unusually it can affect other joints. But the classic episodic joint involvement, if it is not present and if the uric acid is raised, one need to consider a possible other differential diagnosis. At that point, if you go back to the patient and see skin lesions, especially of psoriatic type, moderate to mild or even extensive psoriasis, that suggests the reason for elevated uric acid. The other markers, especially which are used as criteria for diagnosis, we have rheumatoid factor and anti-CCP, which is a part of ACR-ULR scoring system for diagnosis of rheumatoid arthritis. Anti-nuclear antibodies has been taken as an entry criteria, especially it should be positive at 1 in 80. When it positive, one can think and consider possibility of rolling towards scoring system for systemic lupus erythematosus. So the presence of these markers not necessarily always lead to the diagnosis. So just to give an example, for instance, rheumatoid factor, we have two different methods to assay the rheumatoid factor. One is a latex agglutination method where it is easy, cheap, but only problem is it's semi-quantitative. Inter-assay variability is quite often subjective, and if not taken care, prozone phenomena may result in false negative results. And similarly, we have nephelometry, which is an automated assay, rapid assay, very small samples and reagents volumes are required, highly sensitive and gives a quantitative value. So now look at why we say that rheumatoid factor, the presence of rheumatoid factor is not specific to make a diagnosis of rheumatoid arthritis. The rheumatoid factor is not present in every rheumatoid arthritis patient. It is present only in 60% of the patients, and it gradually increases to 80% late in the course of the disease. And other problem that we need to remember is 5% of the normal populations are also positive for rheumatoid factor. So suppose if we take only rheumatoid factor without considering the clinical symptoms, we may misclassify 5% of normal population to be suffering from rheumatoid arthritis. If we follow them, how many of them are likely to develop rheumatoid arthritis? Several studies have shown it's only around 30 to 40% of these patients may develop rheumatoid arthritis, whereas many of them may not develop rheumatoid arthritis in the due course of the time. The same rheumatoid factor gradually increases with the age. It is around 15% when we cross 60 years. Here, the patient may suffer from osteoarthritis, and you have a rheumatoid factor positive, especially at the lower titer. One may be misled to a diagnosis of rheumatoid arthritis. So we need to make ourselves clear that the rheumatoid factor is not specific test, but it is one of the criteria. If it is present with other clinical criteria fulfilling the ACR-ULR criteria, one can consider a possible rheumatoid arthritis as a diagnosis. So there are several other causes or several other conditions where rheumatoid factor could be positive. It can be seen in several connective tissue disease like systemic lupus erythematosus, scleroderma, MCTD, polymyositis, and in Sjogren's, and chronic hepatic and pulmonary condition including tuberculosis, it could be positive. Neoplasm, especially after radiation and chemotherapy, lymphomas, one can have rheumatoid factor positive. Infections, especially chronic infections like hepatitis C virus, HIV, hepatitis B, can have rheumatoid factor positive. Cryoglobulinemias and can have rheumatoid factor positive. Rarely sarcoidosis can also have rheumatoid factor positive. So that puts us to a clear perception or a concept that mere presence of rheumatoid factor doesn't always suggest rheumatoid arthritis. So what I mean is rheumatoid factor positivity is not equivalent to or not equal to rheumatoid arthritis. You need few more other clinical features to call a person with rheumatoid factor as rheumatoid arthritis. So hence the clinical details and clinical history of the patient is very much relevant or very much required before concluding the diagnosis. Similarly, we have other test, anti-CCP. The anti-CCP is an antibody directed against cyclical citrullinated peptide, and it has quite a good specificity because it is seen less commonly in the patients, in the normal individuals. Even the individuals who have anti-CCP positive, majority of them are more likely will develop rheumatoid arthritis. So that being the case, and presence of anti-CCP is one of the specific tests to diagnose rheumatoid arthritis. But its sensitivity is very poor because it is positive only in 41% to 80% of the patient, depending on the population that has been included in the study. So overall, it is a specific test, but it comes at a cost of low sensitivity. But however, in a patient who are atypical in their clinical presentation to call it as rheumatoid arthritis, and if the rheumatoid factor test is negative, in that condition, if anti-CCP is positive, one can make a definite diagnosis of rheumatoid arthritis. ASLO is another test which is often done in patients suffering from musculoskeletal diseases. But we need to remember the ASLO test is performed when you are suspecting rheumatic fever. And other important thing we need to remember that all patients in whom ASLO is positive do not suffer rheumatic fever. I mean, just to sensitize, I'll just give you a little bit of statistics. See, the ASLO is an antibody raised against streptolysin O. So streptolysin O is nothing but a component of streptococci. Anybody who gets infected with streptococci, the ASLO titer increases. So the mere streptococcal infection doesn't lead to rheumatic fever. So if we look like that, see, for example, just to give, 15% of the children carry streptococci in their throat. So the chance of these children having elevated ASLO is 90%. Out of these 15%, 90% of the children who have streptococci will have elevated ASLO. What is the proportion of children who can develop rheumatic fever? It's only 0.08%. So this clearly tells you that if you just take ASLO as an indicator or as a specific test to call a child to suffering from rheumatic fever, you will be mislabeling quite a large number of children as rheumatic fever. So you need to make yourself clear whether the patient or the child fulfills criteria to designate rheumatic fever, whether the joints pains are typically migratory, is it involving larger joint, is there a real inflammatory parameters being elevated or increased, is there any cardiac involvement. So one need to look into these findings, and then only we need to consider a possibility of rheumatic fever, and then one should think of putting the child in for prophylaxis. So next comes is the anti-nuclear antibodies, which can have different pattern, and it is supposed to be one of the serological hallmark of SLE. And the detection is done by several methods, and there are many techniques available. We have indirect immunofluorescence and ELISA. And ANA also has different patterns, and you could see the one which is homogeneous, and you could see the nucleolar pattern, and you can see core speckled, and this is the nucleus is negatively stained. There is no staining, and you could see the periphery being stained, which is called as cytoplasmic positivity. So there are several conditions where we can see anti-nuclear antibodies. The ANA positivity is useful in concluding the diagnosis of SLE, systemic sclerosis, inflammatory myositis, and Sjogren's syndrome. Look at the percentage of these connective tissue disease positivity. Lupus, it's around 95 to 100. As you move down, the number of conditions where it could be positive comes down. So what it means is Sjogren's syndrome can be ANA negative. Lupus can be rarely ANA negative. So the condition where the ANA has been used as a criteria. So usually we use ANA as one of the criteria, especially while diagnosing systemic lupus erythematosus, autoimmune hepatic disease, and in mixed connective tissue disease. Here, ANA is one of the diagnostic clue to consider a possibility. In all these patients, this is 100% positive. The disease where ANA is useful for monitoring and prognosticating in juvenile chronic arthritis. If ANA is positive, their chance of developing uveitis is high. Similarly, when an individual, especially young female, comes with Raynaud's phenomena, if ANA is positive, the chance of she or he developing connective tissue disease is higher. So it helps as a prognosticate marker rather than as a diagnostic test. Similarly, in cases like rheumatoid, multiple sclerosis, ITP, thyroid disease, sometime in DLE and varieties of infections and malignancies, we can see ANA to be positive. So thus we need to remember ANA is a good screening test for SLE. ANA positivity doesn't mean SLE, because now I have clearly mentioned that we have several other conditions where it could be positive. And ANA negative SLEs are unusual, but you see in end-stage renal disease, neurolupus and subcutaneous lupus erythematosus, positive ANA leads to suspicion of SLE, and one need to work it up further with dsDNA and ANA profile. And there are a few other tests which can help, like HLA-B27. It's a class 1 MHC antigen. Its presence suggests a possibility of spondyloarthropathy, Ritter or psoriatic arthritis, and it is taken as one of the criteria by ASAS to make a diagnosis of spondyloarthropathies, axial spondyloarthropathy. HLA positivity is only in 20% of the people with HLA-B27 ever develops. We need to remember that positive HLA-B27 doesn't mean they develop ankylosing spondylitis. It's only around 10 to 20% of these patients are likely to develop ankylosing spondylitis. When it is monoarthritis or when the diagnoses are incomplete, synovial fluid analysis will help, especially in monoarthritis. When you are suspecting possibility of infection, synovial fluid analysis is a necessity. We need to aspirate the synovial fluid, subject it for crystal as well as for the cell count and proteins and glucose and other assays that will help in making a reasonable conclusion, especially in excluding infection as well as the crystal arthropathy. The synovial fluid analysis is extremely helpful. In polyarthritis, usually it won't contribute much other than the polyarticular gout or crystal-induced arthritis, and sometimes unusually oligoarticular presentations could be there in infections. However, in presence of inconclusive diagnosis, one can look into synovial fluid analysis as well as can go for synovial biopsy. Radiologies of joints like X-rays, MRI, ultrasound, CT scan, nuclear imaging and other modalities are also helpful, and it has to be used wisely in making getting the appropriate information in concluding the diagnosis. Just for example, X-ray of the joints, especially of hands, both AP view or ball catcher view can help in erosions and also in differentiating osteoporosis. Pelvis AP and dead lateral sacroiliitis especially gives a clue for ankylosing spondylitis. Presence of bamboo spine, alkaptonuria, degenerative changes can help us in differentiating several differential diagnoses, because bamboo spine is angstpond, alkaptonuria has the calcified disc space, degenerative changes like syndesmophytes, which are horizontal, helps in concluding degenerative changes. Affected joints will help us to consider osteoarthritis and also helps in understanding the extent of damage. MRI can help especially with reference to sacroiliac joint, whether presence of sacroiliitis is there. It can help to differentiate tuberculosis from ankylosing spondylitis, but sometimes it may be very difficult to differentiate even through MRI. Degenerative changes, disc diseases and infiltrative diseases of spine can be made out. When you are confused, especially very early, minimal early changes, MRI of hands and joints can identify pannus, erosions and the extent of damages. So overall, as I said, step 1 is to establish the inflammatory nature. Step 2 is to confirm the diagnosis using RA, rheumatoid factor, ASLO, ANA, and evaluate the conditions to figure out the extent of the disease. Here you can do radiological imaging and also damage to other organs. But here it basically depends on what is the diagnosis If it is rheumatoid arthritis, we usually estimate the amount of joints affected and whether joint has gone for erosion or a bad damages, and one can plan for imaging to estimate the damage. If it is a long-standing rheumatoid, one has to look for extra-articular features like chest X-ray and vasculate neuropathies and other changes. In systemic lupus erythematosus, a good full screen of organ involvement like renal, pulmonary, neurological, both clinical as well as through investigations one can look. So investigation depends thus on the system that needs to be evaluated and the symptom of the patients that are present. For example, in SLE, if there is a proteinuria, one has to look for 24-hour urinary protein and kidney biopsy, skin involved skin biopsy if we are confused about the possible diagnosis. So that here estimating the extent of involvement depends on the disease as well as the signs and symptoms what the patient have. So to look for the associated conditions, evaluate liver, presence or absence of diabetes mellitus, renal involvement, any infections, and lung conditions. So to monitor response of therapy, we use inflammatory parameters, dsDNA, ANCA, and some of the very few of these autoantibodies are helpful. More often it is the clinical feature as well as the inflammatory parameters like the CRP, ESR, and in SLE the complement levels. And so based on the organs involved, like if it is renal involvement, urine protein, urine active sediments are all considered as one of the parameters for measuring the progression of the disease activity. So thus, we step by step we will look into all the conditions, and once we have all the tests, one need to interpret it smoothly. So it's best not to answer or ask for panels. Don't ask for a long list of tests. Choose the test properly. So otherwise we may sit in a condition where we will not know what test to give, how much of importance. So for example, in a patient who doesn't have any symptoms, if the rheumatoid factor and ANA comes positive, you really don't know what to do with it, because they don't suggest rheumatoid arthritis and they don't suggest any disease to come in the short while, but you really don't know what exactly we have to do. So that's why you have to carefully choose the test and evaluate the patients properly from the clinical perspective. And once you have all the results in your hands, analyze them properly and come to reasonable conclusions. There you are with a complete picture of the problems. And once you have them in right way and right direction, you should be ready to solve and conclude the diagnosis. Thank you very much for patience hearing.